Hi, it's Jonathan,
Hi, Amy.
and welcome to the case. And Amy's here, so obviously we're talking ultrasound. And look, I've got a case, Amy.
Okay.
It was actually a bit tricky. It was a lady who didn't seem too unwell, but turned out to be pretty unwell. And ultrasound actually really clinched it for me. So it was a 47-year-old lady who had a history of dyspnea. She'd been short of breath for 2 weeks. She'd seen the GP, 2 courses of antibiotics, treating her for a flu-like illness, maybe a bit of steroid for asthma, but she wasn't really an asthmatic. And she came to see me still short of breath, and mostly short of breath on exertion. So, I examined her, and well, there was nothing else to the history really. A bit of a cough, but non-productive, no travel, no DVT, really nothing much else.
Okay. And what did you find when you examined her?
Pretty normal. So normal oxygen saturation, respiratory
wheezy?
rate, not wheezy. Respiratory rate was up a little bit, maybe 20. And that was after I walked her into the room, but really, really nothing. So it just sounded clear. Heart's okay. And I thought, well, hell, I'm not sure what's going on. Let's, is it nothing? But it's got to be something, because she's a sensible person. She's out of breath. And then past history, there wasn't much. Hypertension. She had a remote history of breast cancer, which, just made me think, is it something else? But again, examination normal. And so I did a chest X-ray.
Well, what did that show?
Yeah, well, guess what it showed? Absolutely nothing. So it looked completely normal. So I've got a normal X-ray. What else would you do, like tests-wise?
ECG?
ECG. Yeah, look, I ordered an ECG. I didn't see it for a while.
Right.
So let's hold that thought. ECG. And I'll tell you, a little bit tachycardic.
Okay.
Yeah, but that's about it.
And what about bloods? Were they helpful?
Yeah, so I did blood. She certainly wasn't anemic, because anemia would be cause for dyspnea with a normal chest X-ray, but she didn't look pale, so she wasn't anemic. I did all the viral swabs, and then I had the X-ray. So normal X-ray, 47-year-old woman, short of breath. Is there something else we could do?
Okay. So I suppose you've got something's not sitting quite right with you.
It's not quite right. And I don't know whether I should investigate further, or whether we should just treat her, as a GP, as any reasonable person would have done, maybe another course of antibiotics, but there wasn't enough to say that that's all it was. And I was just wondering, what am I missing?
Yeah. So I suppose an easy thing to do would be, especially at the bedside, would to do just stick a ultrasound probe on and see if you could find something.
Sure. So, I thought that. And look, my lung ultrasound is okay. My cardiac ultrasound's okay. I did look at the lungs. Looked okay.
Right.
Yeah.
So not much mind lungs. And did you have a look at the heart at that time?
Yeah, and then I looked at the heart. And what do you reckon I saw, Amy? What are the possibilities? I mean, that's what it comes down to. So, when you do a test, you want to think, what might I find before I actually, when I do the test, what are the possible outcomes?
Yeah.
So
you're asking a clinical question when
I'm
you
asking
test.
because what I'm asking is differential diagnosis of someone who's short of breath, has a normal chest X-ray.
Okay.
Yeah.
So did you find a pericardial effusion on ultrasound?
Oh my God. You picked it. So here's what we saw on ultrasound. And I'll tell you, whilst we look at these images, that she did have the sinus tachycardia, but her voltages were okay on the ECG.
Okay.
Yeah. So
any electrical ultrasounds?
no,
ECG?
no. And electrical old man's, the significance of that, just remind us.
So basically that means that if there's a pericardial effusion and the heart is beating in a bag of fluid,
big effusion.
There's a big effusion there, and
no, normal, no alternans. But here's the ultrasound, and what are we looking at? Take me through.
All right, so this looks like you can see obviously the heart, and then you can see that there's a anechoic or a black rim around the heart, suggests that there's fluid in the pericardial sac.
And to be honest, when I looked at it, I thought, hang on, is it fluid or is it just fat? Is there a way? Because I've been tricked with that. Have you been tricked with that?
Yeah, once or twice. So usually, fluid is a bit more black.
Yeah. Okay. Yeah.
Than fat is.
So and it definitely was black. So and I thought, same blackness. I know this is not very technical. Same blackness as the contents of the ventricle. So it's blood. It's as black as the inside of the heart. So it's got to be fluid. Definitely was fluid. Okay. What else?
All right, so you've got you've diagnosed pericardial effusion now. Why do you think she had that?
Well, this is the thing. Again, it comes down to, well, in this case, there's maybe a viral illness 2 weeks ago.
Mhm.
So that brings into things like pericarditis,
Mm.
or a myocarditis, which might have an effusion with it.
Mhm.
But then there's also the remote history of the breast cancer.
Yeah, so is it something
And
malignant?
is it something malignant? So we've got a malignant pericardial effusion, which is obviously the news we don't want to hear, but it's a possibility. And then really, what else? Not a lot else. Other reasons why and we've spoken about anemia.
Mhm.
I guess a pulmonary embolism would be the other thing.
Yeah,
But not causing pericardial effusion, but causing her to be dyspneic,
sure.
with a normal X-ray. But it doesn't look like a PE. It looks like a pericardial effusion.
Yeah, and you've
Yeah.
actually found that without
Yep.
doing another invasive test.
I've done nothing else. So, okay, so we found a pericardial effusion. Boom, that's the diagnosis.
Mm.
But does it stop there?
Well, then you need to look at, is she actually showing signs of tamponade because of the pericardial effusion?
So is it a trivial thing that she's had for ages and is
Mhm.
not actually related to her current symptoms, albeit important, or is it something really serious? So let's have a look at this. Has this person got tamponade?
Okay,
Yeah.
so you can
Yeah.
see the difference in
Yeah.
the first case in this one is that this one you can see that the right side of the heart is collapsing. So usually the sonographic signs of tamponade are when the right atrium collapses in systole, so when the heart's trying to contract, and the right ventricle collapses in diastole, so when the heart's trying to fill. And that often looks like someone jumping up and down the trampoline or a seesaw.
The seesaw sign. So it just kind of looks wrong.
Right.
Yeah, that's how I think of it. It looks wrong. So it's collapsing the wrong way,
Mhm.
and that means tamponade.
Well, that along with what the patient looks like clinically. So were they
Okay.
hypotensive, looking a bit sick?
So in our case, she wasn't, but
Okay, good.
yeah, she looked good.
Yeah.
But so again, signs of tamponade. And I guess early tamponade versus late, and what's the sequence? Does one thing happen first and the next thing, or increasing signs of severity of tamponade?
Yeah.
Yeah, because I reckon she's early.
Right.
Yeah.
So the earliest sign would be the right atrial collapse.
Okay.
And often that's actually trickier to see on ultrasound. So often you get a better view of the ventricle, but that's a more later sign when the ventricle is collapsing. And also don't forget to look at the IVC as well.
Okay, so it's right atrial collapse.
Yeah.
Yeah.
In systole.
In systole. Next thing.
Right ventricle collapse in diastole.
And then the IVC.
And then don't forget to look at the IVC. So if the IVC is dilated and non-collapsing, then there's a suggestion of obstructive shock, which in this case, we're thinking tamponade.
Okay. As it turned out, she had some right atrial collapse.
Right, okay.
And that's all. So, this lady who we answered the question on, we found out what the cause of her dyspnea was. We got her admitted. So
so it really changed
so it actually really changed the disposition. So the ultrasound changed the disposition. She got a formal echo. They watched her for a little while, and it looks like she's probably going to go for a pericardial window. It looks like it's actually a recurrence of a breast cancer.
Okay.
So although that's not great news, ultrasound actually made a big difference.
Yeah.
Because otherwise she'd be off on the merry-go-round of getting more tests and getting things worked out that perhaps were the wrong thing to do.
So often these ones, they're admitted because something's not quite right, but they actually don't get diagnosed until a few days into their stay.
So I think it made a difference. We were able to pretty well, in emergency, work out what the problem was and get it to the right disposition. So not a great case for her, but at least we sorted things out.
Good work.
All right, thanks, Amy.
Thank you.
We'll see you next time. Bye.